I think we'll get started for those of you in the room, and then we have those joining on Zoom. Welcome to UVA's Medical Center Hour. I'm Margaret Hayes. I'm a primary care doc and faculty at the UVA Center for Health, Humanities, and Ethics. Today, we're very excited to be hosting Dr. Jessi Gold for a really important conversation on staying human in healthcare. A few quick logistics to begin. First, this event and this bringing Dr. Gold to campus is a partnership between Medical Center Hour and the Center for Health, Humanities, and Ethics, and a bunch of other wellness groups on campus, the School of Nursing's Compassionate Care Initiative, the UVA Center for Faculty Wellbeing and Development, and the Wisdom and Wellbeing Initiative, the School of Medicine. So thank you for all of you involved, and for Dr. Gold for giving us the occasion to all work together. In terms of logistics for continuing education credit, the code has been circulating and it's on flyers out front too. If you have any questions about claiming credit, you can email Shirley Kaufman up to 7 days after this event to claim that credit. And then finally, we'll have some type of Q&A after the talk. For those of you in the room, I'll have a circulating mic. For those of you on Zoom, you can use the Q&A feature on the webinar, and I'll monitor that and moderate as needed. So now to introduce our speaker, Dr. Gold is the Chief Wellness Officer of the University of Tennessee Health Sciences Center and an Associate Professor of Psychiatry in the College of Medicine. In her clinical practice, she sees healthcare workers, trainees, and young adults. She is also the author of the memoir, How Do You Feel? One Doctor's Search for Humanity in Medicine. Thank you, Dr. Gold.
And the people in the room, I might have to do that. Can you hear me if I do that? Cool. I might move because I'm a mover and I'm short. So sitting behind a podium is hard for me, but I will do my best. Thank you for hanging out with me today. My disclosures, so I have different disclosures. So the disclosures that you care about, the ones that are like, do I have things that are problematic and I shouldn't be talking about it? I don't have those disclosures, but my disclosures are the ones that I've realized over time giving these talks. So like the first is that not only is my perspective my own and doesn't represent my state school university, it's also, wellness is a really intersectional topic. I speak from what I know. I'm a psychiatrist who still sees healthcare workers, trainees, and students as patients. So I know from that, but I think different people have different perspectives on this based on what they see in their work. I like stupid cartoons. I like humor. It doesn't mean I think this topic isn't serious. In fact, it's because I think it is. And it breaks it up a little bit. But don't think it means that I don't think it then is important. And then I've been told sometimes like briefly mentioning COVID can be triggering for people. I get it. If you need the space, take it. Also, I would say the most common trigger is that people just hate wellness talks. And so you already hate me. Hopefully by the end you won't, but if you do, maybe hate me less, that's also a win, in my perspective. I'm gonna do as best as I can to just talk about burnout in healthcare, but do that through my own personal story. Talk about culture. I really like culture. I have an anthropology background. I have a master's in anthropology, so I think a lot more about healthcare culture than most other people that do this stuff. And then talk a little bit about strategies in the management teams can use. She mentioned this, but I've learned over time to put this in slides because nobody realizes, and I've learned this too, how big Virginia and Tennessee are lengthwise. So I like to put this in here because when people are like, she's the chief wellness officer for the University of Tennessee system, it means absolutely nothing to anybody. I live at the Green Dot, that's Memphis. That's where the Health Science Center is. It's where I practice psychiatry. With my administrative hat, I have parallel leadership where I'm looking at well-being on all 5 of the campuses. So that ends up being about 64,000 students in our most recent enrollment data. The big one that you see on TV is Knoxville. That is the flagship for us, but we're spread all throughout with very different campuses from Knoxville to the tiny school in the middle, which is a formerly Methodist university, about 1,000 students. So I ended up calling my book this kind of coincidentally, but early on in the pandemic, especially, I started to put this in slides because it forced me to ask myself and forced everybody else in the audience to spend 1 second asking themselves that question. I learned really early on that I never stopped to ask myself how I was feeling. I just spent a lot of time asking other people. And so I started putting it in slides and I found like that was helpful for me and other people. So those of you online, those of you in prison, take 1 second to answer this question for yourself. Um, and then I'm going to put the people in the room on the spot. But like, how many of you said this or this as your answer? Raise your hand. Yeah, that's about right. I just gave a talk to like lawyers and people in audit and compliance, and none of them raised their hand. And I was like, I don't know what you said then. I was like, I've given like some version of this conversation so many times, and it's usually about 2/3, which I think is fair. But 0 felt like a big outlier, and I don't know what to make of that. But either way, so okay and fine are not feelings. Turns out. So we spend a lot of time answering this question, like, how do you feel with not feelings, which is interesting. I think it's a lot of times because that question has a lot of weight to it, but we don't actually think of it as having a lot of weight to it because we think of it as like sort of casual high conversation. Like, look, I said, how are you? How are you? Are good. We're fine. Da, da, da. And you kind of keep going. My favorite acronym for fine is feelings I'm not expressing. I think that's awesome. There's one where the F is a curse word, and some people know that one too. But I like the feelings I'm not expressing one because I think in so many ways, like we laugh because it's true, right? Like that's really what fine means. Like most of us aren't fine, but we're fine for the purposes of this conversation. I've thought a bit about like why, especially in healthcare, we're always okay and fine. And I think the first reason that I've kind of come to understand is that like we're very much taught that the patient comes before us. I don't think that's wrong. So we just clarify that. I don't think that like learning to prioritize the patient in a caregiving field is the incorrect way of assuming things. But I've heard from so many people that this has looked like anytime you then have a reaction that like you get dinged for having bad boundaries or you're taught that somehow you're not supposed to do that. And so the message that you get isn't like, of course, patients and work come first, but is sort of like, but how dare that also affect you? And so you learn pretty quickly to like shut it down because if it does affect you, somehow that makes it about you, and that wasn't the point. I hear that very often from students and trainees, and then I kind of see it echoed throughout. Then I would say this idea that like no one else is reacting and I don't want to stand out. So I hear a lot from people when I'm like, when did you learn about emotions in medicine? Like kind of across the board, people say codes. Successful or not, what happens is like there's an occasion and an event, and then people go to the next patient or they go to lunch, right? Unfortunately, that's sort of how we're set up. And as a student, as a trainee, you kind of learn like this stuff just happens. We don't react. We go to the next thing. Everyone else seems to shut it down. We don't like to stand out. In fact, wear the same clothes, right? So standing out for emotions doesn't seem like the greatest thing in the world. I wrote this piece. I put some narrative stuff, like extra narrative stuff in here because of who asked me to come hang out. But I wrote this piece when I was in med school about this time where I, for lack of a better summary, was tricked into doing cardiac massage on a patient who was already dead. I was on like a trauma surgery rotation on call as a med student, got called into the case, had no idea what was going on in the case, but sort of like the attending was treating it very much like I was somehow gonna do the things to save the person. So I was like learning cardiac massage on this person in the middle of a trauma, injecting epinephrine into his heart in the middle of a trauma. And then pretty quickly, like found out through the way that he communicated with the anesthesiologist around time of death, that that was not the case, that I was kind of like told to come in and the person was already dead, but they were just acting like it wasn't the case to teach me how to work in an emergency. Based on sort of him saying like, it's been a while, and of course that makes sense. And as a student had tons of reactions to that. As an empath and as a person who had never seen someone die yet either. I wrote this piece sort of about that reflection, but also like what happened was the other med student was super jealous. Like the other med student was like, oh, that was so cool. I wish I got to do that. And I was sitting there with these like really conflicted emotions, being like, it was that cool. And like, I'm pretty sure he tricked him. I'm pretty sure that was like a weird teaching assignment. Um, and I kind of learned pretty quickly that like maybe the way that I thought about things and processed things was like a little incompatible with medical teaching. And what people like sort of the competitiveness of medicine. And so like I didn't say anything because there wasn't space for that. And so kind of shoved it down in that same sort of like, well, I don't want to stand out. You said this was cool. I must be wrong. It's obviously cool. I was not, but that sort of prompted the lens in which I look at medical training and started reflecting on medical training and sort of power dynamics. Then I would say there's this thing called perfectionism. A lot of us are just like innately overachieving perfectionist types. The field might encourage that and self-select for it. But for some reason, I think that we think emotions run counter to perfectionism. That like if we say we're not okay and fine, we'll no longer do any tasks today. In fact, all of our tasks will be done because the feelings will take over and then we will be unproductive and we will make a mistake or whatever it is. And I think that that's what I hear a lot from folks and have felt myself too. Big emotions are scary in that sense, and they run counter to sort of this image, which is sort of the last thing, which is that like our field was founded on stoicism. And I put resilience in kind of quotes because more than any word I've ever used for healthcare workers, it's like the most triggering. But I also think it's just because we use it wrong. And so what it's come to represent is like, no matter what they throw at you, you should be able to tolerate it. And therefore, that is resilience. And look at us, we're resilient. And like, that's not what it ever meant. But when you look at sort of the people who become leaders or the people that you're like, as a younger person, sort of growing to become, they're not talking openly about feelings and they don't look like they have feelings. And the field and all of the people who founded it did not have feelings either. And so we sort of see like the whole high, like this idea of being stoic and resilient. So in other words, I sort of feel like we're taught that this is what we should be doing. This is one of my favorite cartoons. I have a printout of it in my clinical office. But basically, I feel like we're taught that if like I just bury it like over there, or I have a feeling I put it over there, I have a feeling I put it over there, it's cool. It'll just stay over there because that's how that works. But in my experience and like so many of my patients' experience, I think it's a bit more like a beach ball where like you push it down and it's like hanging out underwater for a little while, but at some point when you least expect it, it's sort of like more aggressively whacks you in the face, right? So no control over when and also the severity of it. And oftentimes by putting it over there, what comes out more when you least expect it and the higher force, right? And so I think we have this idea that somehow we can practice doing that, that it just doesn't work that way. And then I would argue too that there's this other reason that we're always okay and fine. And I actually think it's because we don't know we're not. And that sounds weird because we're trained in this and we know signs and symptoms. And I can probably ask you to rattle almost every mental health sign and symptom off, and you'd be like, here, this is this. And like applying it is a very different thing in the setting of a culture that normalizes unhealthy behaviors. So I'm going to do my best to kind of like tell you my story of this, to how easy that is and how I ended up in the situation I ended up. Not because I think my story is like novel, but actually because I think it's not. But at the height of the pandemic, I worked at Washington St. Louis. I was a psychiatrist who ended up seeing healthcare workers and their dependents like almost exclusively in my clinic. I was doing telehealth, never done telehealth before, which should not surprise anybody in here, but I was not trained in it, so that was hard. I'm an extrovert, so being at home was already its own kind of problem. And then I volunteered myself into being in charge of faculty and staff like well-being for the hospital system because I asked the question which was like, oh, I see all the stuff we're doing for students and residents. Like, what's the plan to help everybody else? And then they said, good question, Jessi, what's the plan? And I made that plan and carried out that plan as a 1 year out of residency person who was also at home doing all this stuff. And so I was doing a lot of talks, I was doing a lot of all this other stuff. And I had a lot of guilt about being a frontline worker who wasn't frontline because I was behind my computer. And so, like anybody who doesn't want to feel big feelings, I worked more to counteract the guilt. So at home doing all that stuff. And in the process of that, because my primary populations have been like healthcare workers and college students, and I had a decent social media account, I started doing more media. And this reporter was talking to me about like what burnout is and all this sort of like things you would ask an expert. But then at the end of the conversation, she's like, hey, Jessi, what's this experience been like for you? And I'm media trained enough to know I was still on the record and that was not me. But I was having a day where I was like, I'll just be truthful. So I said the answer and then didn't really think about it. And then about a week or two later, she texts me and she's like, hey, I just wanted you to know that the tone of the article changed. I hope it doesn't freak you out. I'm like, all right. What did I say? I'm gonna get in trouble. I don't remember. Sometimes I black out when I'm talking media, even though I'm talking points. That's not good. And then the article came out. This was the lead paragraph. So, like, for those of you who maybe don't read a ton of newspapers, the lead paragraph is like the clickbait part, right? It's the part that we like, the thing that they most think will make you read the rest of the article. The thing that if you get like a New York Times Digest, is going to be the only thing in it. Is that one sentence about me, which is me, the patient, not me, the provider, right? So I very quickly went from the expert to the patient. And I was like, oh, that's interesting. And I wasn't mad at the reporter, which is doing her job. I wasn't actually mad at myself because I answered the question. What it actually made me think about was like, why is that interesting? Like, why is it interesting to the New York Times, which some might argue is the top paper of this country, that I, as a psychiatrist who sees healthcare workers in the middle of a pandemic, am affected by my job? Yeah. Why is that interesting? And it's interesting because no one else was saying they were affected by their jobs, right? And then I was like, what's the deal with that? Like, why aren't we talking about it? And like, why is this novel? And so I started thinking a bit more about like what I was seeing with patients. And what I noticed a lot was that like we really measure everything by work. Can I show up at work? Am I doing my job at work? Can I be at work today? That's how we measure all things. We learn that in school. So if you ask my college student patients, are they doing okay? They would say, yes, Dr. Gold, I have all A's. And then you'd say, well, what's the rest of your life look like? And they're like, I haven't left my room. I drink all the time. I have no friends, but it's because I have all A's, right? We learn that really young. And so once you go into the workplace as a sort of young, overachieving perfectionist type, you're like, well, in fact, I'm getting more positively reinforced at work when I work more and overwork than when I don't. And so I'm doing great. Work says I'm doing great. And so you're really not paying attention until it's really quite bad. I had the fun of like doing that while also telling everyone else they're burnt out, which is like a whole weird mind trip that you can do that, where you're like, I'm great, like you're burnt out and you're burnt out. Most of my healthcare worker patients tell me like when they come to my office that it's okay because they haven't hurt anyone yet. That's a terrible measurement. Okay. And whenever I say that and I'm talking to patient audiences, like their faces get like very nauseated looking, like, what are we dealing with here? Right. Like that's bad, but that's true. Like, look at your coworkers. Like they think it's okay that their life is messy because they didn't cut off their own leg yet. And so they're like very proud that they haven't gotten to that point and they didn't have to get to that point to be forced to show into my office. Right. Like that's messy. Part of that is just simply because like what burnout actually is, right? So like it's a workplace associated condition, which most of the folks, especially in this room, know this very well, meaning it comes from the places that we work in, the systems that we work in, but it's a cluster of three things. And like the first one's emotional exhaustion. By a show of hands in this room, who is not currently emotionally exhausted? Yep, that's right. So 0 of you. So what is it? How like what kind of measure? Like that's impossible. Every single one of us is emotionally exhausted. So I'm pretty sure we're just supposed to be emotionally exhausted. Then you move to the next cluster. Depends on who you ask. It's either cynicism, and anger is a much more acceptable emotion in medicine than sadness or anxiety, especially in surgeons. But we go cynicism or depersonalization. Depersonalization is that thing that we learn to do to not feel the things that we're hearing and seeing, but all the time. So it's subtle, right? Because you're kind of like, hey, I'm doing that to protect myself. And that's how I don't get affected by my job. And then all of a sudden, you're doing that all the time in all settings and have no more empathy and don't know where it went. But you have no idea because it started out as like a way to protect you. And it was right at that time. And it probably still is right, but it's just like to an extreme extent. So again, sort of that subtle change is really hard to identify. Then you go here, sense of reduced personal accomplishment. Now that's the one where you show up in my office because someone said you're doing less, you feel like you're doing less, you actually are doing less, right? That's where it starts to affect work. So that's like literally the only thing that you might notice. And again, that's probably like not a tiny mistake, it's a bigger one because we're pretty good at like getting our stuff done no matter how we feel because we did that on call. We did that with terrible out. Like we're kind of like, well, I have a decent day now, so good for me. I also put in my favorite definition just because I think it helps, which is it's a mismatch between what you think work is going to be and what work actually is. And the reason it's my favorite definition is like most of us wrote essays being like, I just want to help people. I don't think we wrote essays like, I just want to document and talk to insurance companies. If you did, medicine is really just living up to its expectations and you're really loving your job every second of every day. But that difference in like what we thought we were getting and what we actually are getting is where a lot of burnout comes from, which makes sense because none of us like that stuff. We didn't sign up for that stuff. Even if people warned us, I remember people warning me about managed care and I was like, who are you? You just don't know. I must know more than you as like a little college student and still went through the process and was like, no, they were right. I just don't listen. So we go from like, is it affecting work to like, actually, I'm pretty sure this is just what work is. Like we all feel like, right? So I picked two social media posts that I feel like help explain this. And like one is more specific to people who work in mental health, but I think it would make sense to anyone, which is being a therapist right now feels like handing out sunscreen and people are on fire, right? So that idea of feeling ineffective if like things keep happening and you can't fix it is like very prevalent in that statement, but that's also very just innate to the work. The second one I picked more recently because I just thought it was ridiculous and I decided I needed to start putting it in talks, which is this guy posted really enthusiastically about how good of a leader his department chair is because he came in at 2:30 and started seeing patients despite the fact that his home might have burnt down in the California fires. Now, you might say to me, hey, Jessi, he had nowhere else to go. Valid. You might also say, hey, Jessi, it's a little late to get coverage. Okay. You might also say to me that that's a heroic measure, which someone has stood up and yelled at me about. And there's fact in all of that. But the thing that I would say about this is like the idea that that is leadership, right? That like being a good leader means your house can burn down and you show up anyway, means that like being burnt out doesn't register on a Richter scale because that scale is obscene. Like the scale is like your whole life could have burnt down and that's cool because patients come first, right? Like that's a bad measurement. But it makes it really hard for people to go like, well, how does this fit in? There's also this study, which I wish someone would do in other fields, but we'll just take with a grain of salt that it's in surgeons because I actually think it would be the same no matter what. And they had them do the Mayo Wellbeing Index. And then they asked the folks who scored in the bottom 30%, like, how do you think you did? Okay, bottom 30% relative to natural laws. 71% of the folks in the bottom 30% said that their well-being was at average or above average. You could say, but Jessi, surgeons, and I get it, and it's not just surgeons, right? Like this is not a surgeon problem. This is an everyone problem. But what this means is that I'm not sleeping, but like I sleep more than James on my right. So like I'm killing it. Or like I cry a little bit, but so does like this other person on my left. And I think that that's just average to cry a little bit, right? But just because we have a field that has somehow normalized like not eating, not sleeping, not going to the bathroom, being 50% burnt out and about like 27% depressed if you're looking at trainees, like does not mean that that's good. But what that means is like you look around and you kind of go like, maybe this is how you're supposed to feel because everyone feels like that. And if you go, I don't actually want to feel like this, I need help for this, then you start going like something's wrong with me because everyone else is just tolerating this really bad culture that we have. And that makes it really, really, really hard to then know like, hey, it's not just work or it's not acceptable that it's just work, right? I went some fun extra steps in my own burnout, and like my primary symptom was fatigue. I would like finish patients, go sit on my couch and wake up 4 hours later and be like, whoa, how did I fall asleep? I don't remember falling asleep. And so then I would sit there with my eyes, like holding my eyes open, and I'd still fall asleep. And the best way I can describe it is like how I actually felt when I had COVID, like that just heaviness of needing to go to bed and just feeling just crummy. And like any good psychiatrist, I was very convinced that it was a physical health problem. And because fatigue as a differential. And I was like, oh, like there's stuff that could be wrong with me. Let's go figure out what the thing that's wrong with me is. So I made my poor primary care doctor do labs at the height of the pandemic in the parking lot for a very unurgent condition. So to humor me. And I had low B12, like real low B12. And I was really excited, which is a weird reaction to having low B12. But for someone who was like, why am I so tired? That was a really good thing to find. And I was like, oh, my patients really like B12 shots. So like, I'm going to feel fantastic. I can't wait for B12 shots. So I got some B12 shots. I did not feel much better. And that was a huge bummer for me because I was like, that's not the answer. So then I did what I think most of my patients also do, which is like, don't worry, Jessi, in like 4 months, 3 weeks, 2 days, and a half an hour, you have vacation. And if you could just wait 4 months, 3 weeks, 2 days, and a half an hour, you're great. Literally in January of this year, I said to my personal therapist, like, I just need to make it till May. And she said, Jessi, it's January. And I had zero concept that that was far away. Like, I was like, but isn't that how like time is measured? And she was like, Jessi, it's like a really far time from now. But everyone kind of functions like that. Like, if, well, I have a vacation. I just have a vacation. You need to get a vacation. I will never tell you not to take your vacation. We do not take enough of our vacations. We should check all of our vacations. There are a benefit or a reason. However, all it will do is give you like a little temporary bump because you're away from the problem, right? So if the systems are causing the burnout and you're on a beach away from the system, you will feel better. If it's a weekend, you might also feel better. If you are depressed, you are just depressed on a beach, right? Like it is not, that's not how that works. But burnout will feel better away from the cause of the burnout. But you will go right back in as the same person in the same culture, and eventually it will not have had a long-term effect, right? It is a nice little buoy for a while. Depends on if you come back to like 2,000 emails or not, but it is a nice buoy for a second. And then you're kind of like, oh, that wasn't the answer. Like, or you go, it's okay in 4 months, dude. It's, you know, you kind of look again, right? I even went like this extra fun, extra step, which was like, I'm having a conversation with my personal therapist, and I was like, I don't know what's wrong with me. Like, it is not a B12. It's not depression. It is not vacation. Like, what's wrong with me? And she's like, hey, Jessi, you're a frontline worker who sees frontline workers in the middle of a pandemic. What do you think it is? And so I started laughing because it's my favorite defense mechanism, but also just like, I don't know, I laugh about things when I'm uncomfortable. And I was like, you are going to say that I'm burnt out. And I gave a lecture on burnout this morning. And she's like, yep. You know, like sort of like, that's why people go to therapy. And I don't like when she's that right. But basically, I tell you this to say that as a person who is now somehow stepped into being a burnout expert in some capacity, to not even be able to recognize signs and symptoms in yourself that you rattle off every single day means that like I was trained in the same culture all of you are trained in. I worked in the same culture all of you work in, and I could not then turn the lens back towards myself, which means I don't think any of you can either, because there are very few people, except for some of the folks in this room that this is like their job, that swim in burnout as much. And I still couldn't do it, which means it is really hard to notice. And that's okay, but that's also something we should talk about because it's hard to notice because we've become okay with it. And that's not where we should be. Then we sort of go into this like, okay, I can rattle off numbers all you want. I can tell you that you should get help for whatever you're struggling with. But I kind of told you that like we look around and we don't get help. We kind of feel like it's our fault, so we don't get help. If you're a data person, you're gonna really hate that I took a Kaiser poll and put it in my slides, and you're welcome. But it's the only thing that really looked up as well. So it is just what it is for now, which is like ask folks during the pandemic, kind of like what is going on, how are you feeling, but also like who got mental health help. If you look, like 13% actually got mental health help, and 20% were like, I should have. And then they asked those folks why they didn't. And it falls into two categories, one which I'll call systems and one which I'll call like culture. So the systems one, too busy, can't afford it, can't get time off. Valid, 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 valid. All of that is valid. However, systems change takes a really long time, and you need people like me and jobs that are in places to be annoying and point this out to people, right? But not all of us have control over systems. Not the average person working on that average clinic in the average day does not have control over whether their job lets them have access to cheap mental health care in a broken mental health system, right? But this afraid or embarrassed to seek care bit, 17% is a lot of us to be afraid or embarrassed to get help in a field that should not be afraid or embarrassed to get help, right? So that's the place where I tend to put my hat, which is like, how do we change that? Because if we could change 17%, that's a lot more people getting help. And if you change that, I bet that people will start talking about that system stuff a lot more too. It's not to say that system stuff doesn't exist, because it exists, but it's a really complicated to fix. And so I put a lot of like extra effort on this culture part. So I hope this works because I think it does, but we'll try.
Sir, could I talk to you for a second? Oh, sure, Bill. What's going on? Well, my cousin's getting married next September. I was hoping to take the day off to go to the wedding. Cutting it a little close. That's only a year away. Yeah, I guess. Have you completed your paid time off proposal? Yeah, here it is. I got it notarized like you asked. I've included 3 references and a detailed itinerary. I'm sorry, Bill. We just can't risk it. What? I found backup to cover me while I'm gone. But not backup to the backup. Bill, you know we have to have 5 lines of backup before we can let a resident take a day off over a year away. Well, can the attendings cover? I need you to think long and hard about what you just suggested. What? You expect an attending to practice medicine without the help of a trainee half their age with a fraction of their experience? Hey, admin. Oh, surgery. What can I do for you? I'm going on vacation. Oh, okay. When will you be back? I don't know. See ya. Well, have a great time.
If you don't watch his videos, most of them are really about systems. He's just like uses medical humor and stuff to get at them. But the reason this is in here is the same reason I was kind of talking about, like, well, what is the barrier for showing up? I hear stories from patients like that you would think were the same people who are like, oh, I walked 1,000 miles in the snow with my sandals, and but they were literally like yesterday, right? Like people who put an IV in while they're throwing up to see patients, and you say, where do they work? And they say the ICU or like the immunocompromised floor. And you're like, great. We have this culture of showing up, which again is helpful at times, but showing up for like, I'm not actively hemorrhaging means like, where does depression, where does burnout fit? And then I put this other thing because I saw it on social during the pandemic, and I was like, I asked the guy who posted it, like, was this a joke or what? Like, where did you see it? And he was like, well, I don't know if it matters if it's a joke. And it made me think a bit about like where dark humor kind of comes from, and the fact that we think it's funny to put a sign in a bathroom that says cry here, but not out here. Also kind of shows you like where we are with emotions in medicine. Like we kind of are like, it sort of makes sense that right now during the pandemic, you might have a reaction, but keep it over there because I don't want it. Right? That's contagious. Keep it over there. Then there was this paper that was written in the BMJ right around when Simone Biles stepped down from competing the first, like in the Olympics before she went back. And it looked at how healthcare workers are similar to like elite athletes. And I think it's helpful. I'm not going to make you read it because that's silly, but to think about like why we might not see vulnerability as like something that we should be aiming for or proud of. And so she basically argues that like we don't like to fail, and we get put to compete. And in a setting where we're competing and there are winners and losers, and even if we're really trying to help people, there are people who are going to win more than we are. And so vulnerability then becomes not courageous, but seen as a failure because that other person's not vulnerable and that other person can beat us. And then we somehow like frame that into we should not make mistakes. We cannot make mistakes. And so when we do make mistakes because we are humans, that fall is that much greater. And if you look at the data around error, this makes a ton of sense. Like completely in line with higher rates of burnout, higher rates of suicidal thoughts, and higher rates of depression, like a medical error. And some of that goes to this concept of self-valuation, which is like, when I make the mistake, is that on me or am I going to learn from it? And how doctors, this is a physician study, were 50% higher than folks in other fields to be like, no, that's on me. Like, I can learn from that. Like, that was my fault. I'm the problem. Right. And when they looked at our burnout as physicians versus burnout in other fields, like kind of trying to control for self-valuation, that huge difference we have from other fields of burnout went away. It's not to say that we're only more burnt out than other fields because of how we process mistakes. But again, it is something we can work on and something we can control with each other and how we talk about these things. And it isn't this like obscure thing that somebody's going to fix to help us in a system. That has to happen. It does. But it also needs to happen in parallel with like, guess what? You make mistakes. Like you're going to. How do we do that? We see people talk about mistakes and things like M&Ms, right? But no one ever talks about how it heals. They just talk about the steps to do it better next time. Steps are great, but also like actually physically making that error and then having to talk about it is hard. And we should be talking about that too, right? Then there's this fun thing called stigma, right? Which again would be so nice if we didn't have, but people are always like, Jessi, but the med students, they're so much better and they talk about mental health so much more, and aren't they better? And some of that is true, right? So when they asked them when they came in, is it assigned a personal weakness to have a mental health problem? Overwhelmingly, people don't agree with that, right? Like they do not think it's a sign of personal weakness. But when they ask them, like, well, what does everyone else think? Like residency directors, supervisors, fellow students, patients, overwhelmingly, they're like, oh, no, they care about that. Residency directors are going to pass me over. Supervisors are going to see me less favorably. Students are going to see me less favorably. Patients won't want me as a doctor, right? Those are the same people saying it's not a weakness. And then they say, if I get treatment, I would hide it. Look how many people would hide it. How do they go from not thinking it's a weakness to then hiding it? Well, the rest of the noise, right? Which we could call the hidden curriculum in some capacity, but we tend to use that for other things. But I actually think that that's part of this, right? Which is we're saying like they come in and they're like mental health is health, and they leave hiding it and thinking everyone is going to judge them for it, right? So that's on us. Like, how do we fix that? How do we talk about that? How do we make it safer? Because that's a problem. And I will just point out, and not again because I think I'm somehow special, like I actually realized I did this too. So there's a time in the pandemic where all these healthcare workers were sharing on social media about their mental health, like on the artist formerly known as Twitter. And I posted this, and I was like talking about seeing a therapist. Obviously, I'm very comfortable talking about that. I already said her name like therapist like 4 times in this talk. And I was like, okay, that was a good post. I'm so proud of myself at the end. And then I started reading everybody else's, and everyone was talking about meds, being on meds, how I take meds. And I was like, well, that's an interesting conundrum. I've been on meds since college. Why did I not say that? Now, as a person who writes, as a person who really thinks storytelling has power, I actually don't think you owe everyone every part of your story as much as social media would lead you to believe. Totally your boundaries, whatever. But I'm a pretty warm, authentic person. So I was like, there's a reason somewhere that I'm not sharing this. So I took that to conversation with my therapist, and she's like, well, what does it mean if people know that you take meds? And I said, well, it means that they knew at some point I was sicker. Maybe not now, but at some point. It means that every time I have an emotion, somebody's going to be like, uh-oh, maybe she needs to adjust her medication. And it means that I don't know that I want patients, like patients might see me different. And I said that and I like heard myself saying it. And I was like, huh, because I spend all day prescribing to somebody who like literally looks like me, talks like me, is the exact same job as me. And I say to them, oh, getting medication for depression is the same as getting medicine for blood pressure. And, you know, like, why would you just leave your blood pressure out of control? And I believe that. I'm not lying to patients, but I was like sort of lying to myself, right? And so deep down in there, it seeped in, despite being like a very fervent advocate for normalizing mental health, especially in our field. And again, I don't say that to say I'm somehow special, but I think that then to me, that means that the rest of us are definitely dealing with this. Because if you don't like come to me because you think patients are going to judge you for it, or a supervisor or a friend is going to judge you for it, it probably is some validity in what you're seeing and hearing and what you're absorbing in the field. So what can we actually do about this? So I say staying human in a broken culture, because every time I talk about individual and team approaches to anything, people get really ticked off and they say, but like, haven't you seen Epic? And yes. I will never tell you that the system of healthcare is good, well developed, safe, healthy. I could go on, right? None of that is true. Like that, it's all not good. But the problem is, like on a day-to-day, I would like you not to quit tomorrow. And tomorrow, I can't blow up healthcare and start over. I'd like to, but nobody's giving me that option. So that means you kind of have to figure out where you fit within it and what you need to do for you and your team to tolerate the way that it is right now. It's not to say that it won't change, and it's not to say it will never change. It's just to say, well, this is where we are right now. What do I do for me? And it doesn't mean your reactions are wrong, because it is a broken system. So you should have reactions to it. Does that make sense? And I think that for the most part, folks think that I'm going to talk about this, which is for some reason, folks like me, for a long time are like, look, you're valued. Here's a present. And they're just terrible presents. Like the one in the middle is the empty plastic bag. And I said, it says, I know this bag was empty, but it's actually filled with our love and support. Happy Nurses Week. Now, I get sent this stuff all the time, and it's really hard to think because they're all just bad. But we're really terrible than nurses, and I know that you guys have such a prominent like nurse-based look at this, which is amazing. But I think it's really, we're just terrible. But also, we really like to give people rocks. I saw that. What would you do with a rock if you were burnt out? That's exactly how I feel. You were going to throw it. You were going to throw it too. Why are we giving burnt out people rocks? It's a beautiful idea. We think it's creative because it's like a pun. We're like, you rock, here's a rock. Terrible idea. But nonetheless, we like a pun. We like lifesavers for lifesavers. I can't tell you how many of those I've seen. You know, just like, please don't do that to people. But this kind of stuff is silly. So I know that's silly. I know I'm operating under that guise of like this person with a title who probably would give you a rock if they had a choice. And I'm just telling you that I wouldn't. And I'll start there. So what I think, and the reason I start my talks with the how are you, how do you feel kind of thing, is like, honestly, the most important thing and the easiest thing you can possibly do for you is to pay attention to you. That sounds weird. That sounds simple, but it's true. Because I literally had never asked myself, and no one else is going to notice the subtle difference in you, right? So like, this is how we think about stuff, which is, did you know that you have symptoms before you need to go to psychiatry? Right? Before it's affecting work. So like red is like work is affected. Red is you're showing up in my office. Red is your only option in vacation. But like most of us don't need to get to the red. Some of us will because of things called genetics and past history and family history, right? Like that, some of that stuff's not preventable. But a lot of us could have paid attention a lot sooner, and then we would have been able to do something different. So early warning sign of burnout for me is emails make me really mad. Not like a little mad. Like if I broke my phone into pieces, watched it break in pieces, I'd be so happy because somebody couldn't contact me for a tiny amount of time, right? Like that's an obscene amount of anger. And I realized that was a lot of anger. And I was like, what's the deal with that? And then very quickly sort of thought about it and was like, oh, you know what? When you are angry at an email, it is because emails are tasks, even if the task is a reply. And if you have zero capacity, your brain is like, no, like, how dare you keep them away from me, right? The anger is actually, I don't have capacity. And so learning that was like really helpful for me because that was a long time before I was falling asleep every day after work, right? And so that's what it looks like for me. What does emotional exhaustion that is not just a workplace side effect look like for you? I don't know, but that's important to like pay attention to. Because also, if at the red I said go do yoga, you would find that rock and do it all you were just motioning that you would do with the rock. But if that like yellow, I said go do yoga, you'd say, "Oh, what's yoga? That's fun. I've never tried that before." Do you do that with other people? Like it's a time thing. So people get mad that we suggest yoga. Yoga's not the problem. We're suggesting it to a 10 out of 10 burnt out population of people, right? So it is a tool. It is not the tool, but those kind of skills are not the problem. The who we're suggesting them to and how long it takes for them to notice they need them is the problem, right? So like, how do you actually prioritize taking care of yourself? And I just put this in here because so many reasons people are like, but I show up for patients. Don't, you do, but you're not helping them, right? So you show up burnt out. You're like, I'm helping by being here. And you're really not because you're lower quality care, more medical error, longer recovery time, lower patient satisfaction. You can just rattle off all of the data they have on like why being a burnt out clinician is terrible for patients. But we do it anyway. But when you're thinking of like, well, what can you actually do? I think for so long, like people that buy tools or homes for people have made this hard because they've been like, well, my job pays for Headspace. So like, I'm going to use Headspace because it's paid for. Well, if you hate that, stop doing it. That's not the answer. Like the coping skill you'll do is the coping skill that works, right? So I can tell you that all the time in the world of like all the evidence to things working. But if you kept trying that thing and you hate that thing, the answer is not to keep trying that thing. It's to find the other thing that works for you. Because also some of us are different. Like just like we have different learning like styles, and some might be auditory, some might be visual, some might be more like kinetic. It's very similar with coping. Like some people cannot just sit there and be mindful as much as there's evidence to it. Like we can try and it's great evidence, but if you need to go run a marathon and that's what you need, like go run a marathon. Cool. But like try to figure out what that is before you're 10 out of 10 burnt out and recognize it's going to be different for different people and also might be different for you at different times. A couple of like clear cut options to consider. This thing called meaning and purpose. You guys spend a lot of time on this in the things that we're talking about. That disconnect, right? What you think work is, what work actually is, that's meaning. You were expecting meaning when you got paperwork, right? So you have to find ways to find it again. I picked this like little image. It's from a book called Design Your Life. There's one called Design Your Workplace. It's literally just cognitive behavioral therapy adapted for people who don't want to talk about cognitive behavioral therapy, like most business books. But all of that, only reason I picked it is it basically looks like hour to hour in your day and says like what gives you energy, what takes it away. Most of us are like Mondays are terrible, Tuesdays are good, Wednesdays are terrible. But if you actually have a terrible meeting and then a terrible meeting and then a terrible meeting and you have some control over one of them even, like move it to not being back to back. Give yourself 10 minutes in between to go outside. I don't know, whatever that is, you can like adjust your day more around meaning and purpose. You can also think about like what you say yes and no to with this lens. Some things you might still have to say yes to because we work and that's just the way it is. But when people are burnt out, they want to say no to everything. And we forget that most of the things we first say no to are the things that give us meaning and purpose. So I'm very quick to be like, why is this meeting with students at 5 p.m.? I want to go to sleep and eat dinner and not deal with this. And then I'll go meet with students. I'm like, oh, they're so nice. They still like what they're doing. And it's so nice. I feel so much better after. But I forget in the moment, but I would love to cancel it in my head. So I think like paying attention to those kind of things is also really important. I'll quickly also say that like Brian Sexton stuff, all the stuff from Deep on 3 Good Things and like is also really helpful. People get mad that I'm saying like be toxically positive, but literally for 15 days, just the energy that it takes to text back. And people will also say they have no time to cope. Texting takes, I don't know, less than a minute. People had improvements in emotional exhaustion, so burnout, depression, and happiness up to 12 months, and even in the folks that were worse to begin with. 12 months, usually 15 days of texting back for good things. Why does that work? Not because of toxic positivity, but because your perfectionist brain does not need help remembering what you did wrong. It doesn't. You know exactly. You know what you did wrong 2 weeks ago. I don't need to remind you, but I do need to remind you that like before that, you were doing something good. And evolution doesn't help with this either, right? Because evolution wants us to remember we ate a poison berry, so we don't eat a poison berry again. But it doesn't say like before you had a poison berry, you had a really good time with your friends and that made you really happy, right? So trying to be just mindset shifting again, just like as we are with mistakes and as we are, it's just a like way of thinking that can help us kind of like take control back in some of this stuff where we don't have control. That's all from here if you need it later. And then the last thing I'll say, besides meaning and purpose, the big thing is social support. So you can look across the board in data. Even in the pandemic, social support was the most impact on our mental health of anything. Supportive supervisors and leaders fall into this. We were talking about leadership training and how we pick leaders that tend to not be emotionally aware. Fair. That's why it matters, right? Like none of us don't, most of us expect to work hard, but we would just like people to like maybe acknowledge it as something more than a rock, right? Just saying. I'm going to tell you to do this thing that nobody will want to do in healthcare because of the culture of healthcare, which is I believe very much that we can change the entire course of how we treat each other and the culture of healthcare by being vulnerable. The definition of vulnerability is terrible, actually terrible, which is uncertainty, risk, and emotional exposure. Those 3 words are like really just horrible words to put in line and go do it. But I'm going to tell you to do it anyway. And that's because if I disclose, you're more likely to disclose, which is self-disclosure reciprocity, right? A leader who is vulnerable is more likely to be seen as courageous and empathetic, which are values in leaders. And a person who is open to failure is able to be creative, which is also vulnerability, right? So all the things we care about. And when I say vulnerability, I do not mean that everyone needs to be like, hi, I'm Jessi. Here's a story of how I burnt out and didn't know. By the way, I also take meds. By the way, I go to therapy. Like that's a lot. It's a lot. Somebody has to do it. I agreed to do it because the New York Times made I started doing it before that, but they didn't help. But when we had some people do it like that, that's great, just like in some places. But I mean like little moments of vulnerability will change our culture in that you saw a code and you're walking to lunch. You might still have to walk to lunch, but what if you said, it's kind of weird we're walking to lunch right now, isn't it? That's it. Then the student goes, oh, they don't think that's normal, right? You're having a conversation with someone, you can't give them the time off because schedules are complicated. Well, they're not in administration. What would it be like if we actually said, like, let me tell you how schedules are made and also why this is a terrible process, but I can't change it. And that's why you don't get the day off. Now, that makes you not the enemy. It makes the system the enemy. The system is the enemy. That's the point. You shouldn't be holding that for people. You should be transparent, which is vulnerability in a system, and vulnerable with your teams as much as you want. Even if it's just like, today I'm going to be a little cranky because my kid kept me up until whatever hour, and I'm not that nice with it. Good to know. Stand clear. But also, they have kids. Nice. So what I'll say, kind of in conclusion, is that I used to think that if I did more or I worked harder, I would somehow not burn out. This makes like complete like no sense. And then I've thought more about like what we do and what our job looks like and what our expectations of our job should be. And it's a lot more like this quote, which is the expectation that we can be immersed in suffering and lost daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. Why do I like this quote? Well, the truth is our jobs are the water. It is constantly raining. It is not our fault if the rain affects us. It is, however, something we can plan for with a raincoat or an umbrella, something we could talk about because boy, do we love to talk about the weather. And it is not our fault when it happens, right? Because we, for some reason, think when we burn out, like that's on us. Like that's not true. It's actually on the work that we do. And so what I will say is like most of us are not okay and fine. That's also okay and fine. But it's really important that we talk about that we shift the mindset that students come into this expecting that their jobs will affect them so they can prepare to be affected by their jobs instead of being shocked when it happens or shocked that they couldn't have worked their way out of it. Because that was illogical, that for some reason we thought that was the way to train people. So when somebody asks you this question, at least in the next couple days, you'll either say, gosh, that person came and talked that I can't tell you okay and fine, and you're welcome. But I'm actually just hoping you'll find one person to ask that to and want to know the answer and sit and hear the real answer to. And I don't mean everyone, just one person would be nice, because we do need that in the workplace. And asking that and wanting to know the answer and asking it truthfully is a whole thing that would shift how we talk to each other and change the culture one person, one question at a time. I'm verbose and don't really have time, but you can ask your questions anyway, because good thing.
I know we are at time, but we'll give you a quick that a little bit of time before our flight, so you can stick around. Thank you all for coming.
Just a question.
Okay, sorry, do you like 1 p.m. So I think, but
Short round.
not good. I think she's got some time to
Okay, good. It's up to people. I'm fine if you ask it out loud, if you want to ask it out loud.
Okay. Well, I was just curious if you could talk about the difference between burnout and moral injury in terms of how they manifest, but also what you should do about them.
Yeah, thank you. Good question. I sometimes put that in talks, but it sometimes gets long and it gets very definition heavy. So moral injury, the difference for burnout is that moral injury is much more about the actual morals and values of it. That's why it's in the word. So witnessing something you couldn't stop, doing something against your morals, taking part in something that was against your morals came from sort of PTSD literature in the military, being part of a hierarchical system where people were doing things or the government told you to do things that were against what you believed. Manifests a lot more as a stress reaction. So you'll see change in sleep, change in eating, more substance use, a lot of guilt, a lot of shame. All of that is in line sometimes and blending with burnout, but not the same. And the path you got there is different, right? How you actually arrived at it. Moral injury comes on quicker, can lead to PTSD. It thrives in silence. The way to save yourself from moral injury is to have open and honest conversations about this stuff, right? All of us are affected by the fact that politics interferes with the healthcare workplace, or insurance companies affect the healthcare workplace. We might all have different beliefs of those politics or how that interacts, but how you actually are interacting day to day might be in a way that you don't want to as a result, and having those conversations out loud and not just being this is only affecting me because I'm the only person who feels this way, I'm the only person affected by it, is the answer for moral injury. Whereas burnout, you have both sort of the individual solutions I talked a bit about, sort of looking at meaning and purpose. Then you have team solutions really looking at support and how we talk to each other. And then you kind of have system solutions where looking at the stupid stuff getting in the way of your day, your hours, your schedule, flexibility, ethic, all that stuff that somebody else who that's their expertise can talk to you about, but you don't want me to because I'm an anthropologist. But I think both interact. I think a lot of what people are experiencing, especially in sort of post-pandemic times, is much more on the moral injury spectrum than the burnout one. Especially sort of, certain fields and how different choices are affecting what they're able to do.
Thank you.
You can always come up and ask questions. There's also lunch or something. Yeah, lunch. Yeah, that's what I'm in charge of. There's lunch. Thank you, online people, if you're still there. Thank you.